So North West London, what can we possibly say has been said already today? So North West London, Big Ben, out to Heathrow, up to Harrow on the Hill, 2 million people. Penicillin was discovered here. Live at the Apollo is live here. George and Lottie were born here. Oh, look over there. We're here today to tell you why we think that North West London will make a valuable vanguard. We're going to talk about why North West London, what you're going to get from us, and what we need from you. We're going to talk about how these changes will impact our patients and residents. So, why North West London? Well, we're densely populated. So in Hammersmith and Fulham, where I'm a GP, we have 200,000 people in 6 square miles. And we're about to get 60,000 more people. Despite that, our activity in North West London is relatively self-contained. So people get their care in and around North West London. And because of that, we have worked with that basis to have a strong track record of collaboration and co-design through Prime Minister's Challenge Fund, through Whole Systems Pioneer, and through Shaping a Healthier Future. We therefore have a strong track record of delivery and implementation and the scars that brings. So, to give you an example, we have made our A&Es in North West London more resilient. We've done that by going through the difficult steps and the difficult decisions of closing 2 of them. But by doing that, we have got more A&E consultants, more cover at weekends, 7-day working. Within the last 3 weeks, we have closed a maternity unit in Ealing. That sounds terrible. But by doing that, we've got more antenatal care closer to home. We've got better consultant cover, and we've got better midwife ratios. And those things, we believe, are better for our residents. We've done all of that on the doorstep of number 10 and in and around the general election. Just want to talk about the complexity of what we face. Sarah, who's one of our elderly care consultants, could you tell us what it's like trying to get home somebody who's been admitted as an emergency patient in St Mary's Hospital, Paddington? This is not the one in the Isle of Scilly.
An 83-year-old lady is admitted to St Mary's. She's got 7 medical conditions. She's got moderate dementia. She's got 12 medications. She walks with a frame. She needs a bit of help with personal care. And she doesn't need to be in hospital anymore, so we need to discharge her. So we need to know what goes on at home, what care she's got, what support she has. Is she known to community matrons? Does she have a care plan? At St Mary's, she could live in one of 8 local boroughs. Her GP could be from one of 8 CCGs, and she could have input from a number of different community health providers. And each of those has different systems, different assessments, and different processes for discharge. So at St Mary's, it can take days rather than hours to get our lady home.
So what you'll get from Vanguard is, for North West London, for 2 million people, we will standardise discharge across North West London, and we will standardise social care assessment. Another thing that we will bring, Amal, tell us about the integration of primary care and urgent care that you're engaged in.
So, at the heart of any unscheduled care issue and problem is actually the need to integrate primary care, community care, and address the issue of unscheduled care. In Brent Harrow, we've got 100 practices. They're all working in networks for the last 3 years. They all use a single EMIS web computer system. They're sharing each other's clinical data, and they're also beginning to pilot the use of appointment systems with each other's surgeries. There's a network of walk-in centres, and again, we're piloting out the use of each other's appointment systems. What we want to do is now transform the urgent care centre at the local hospitals at Northwick Park and at Central Middlesex to become primary care-led. The GP presence, the senior GPs from Brenton Harrow who will man that service, support the management. I fully agree with you. Children, it's the GP. We know how to manage children far better than the hospital.
So, with Vanguard, we will integrate, because we're in an urban setting, primary care and urgent care. Will it involve mental health?
Absolutely. So that the psych liaison and all these services
Will it involve
from
social
the
care?
from the primary care.
And we did hear about children, but just wanted to cover them off. Well, now, I just want to spend a minute trying to explain what we need from Vanguard. Our hospitals are very close together. How close can two hospitals be in North West London?
I believe the shortest is 2 miles.
2 miles between two hospitals. That gives us a problem delivering things like Keo. Because what are these two hospitals to do 2 miles apart? Alan?
So thank you, Tim, and I'm on the clock. I think with regards to the Vanguard, we have a huge opportunity to look at both clinical and social care models, financial models, test those, implement those and share those as part of being a Vanguard. What am I talking about? Principally from my point of view, we have to work over the next couple of years through a number of challenges in reconfiguring and developing models of care in our 8 acute hospitals that we have in our sector.
Thank you, and Vanguard should help us do that. So, why should you vote for us? We bring scale, we have a track record, we have momentum, and we have passion.
Thank you very much. Like the timekeeping in the star. Right, over to questions now.
I'm sure you will excuse me failing to be amused at the hilarity over children with the worst mortality in Europe. However, what I want to say to you is that in the Northwest there is a fantastic out-of-hospital care for children that you don't seem to have linked up with, which is based around Imperial, which has shown a 17% decrease in admissions from children and a 10% decrease in hospital attendances, plus a shift of appointments to primary care hubs.
So we're working.
I would suggest that you do work.
We're working with Connecting Care for Children.
Good.
One of the things that the change that we've been developing in North West London has done is actually mean that we have to look at all our children's models of care, as well as every other segment of our population. So we're looking at rapid access assessment clinics for children, paediatric assessment units, and looking what the best model of care is, because as you're quite right, there are a number of models of care, and within our complex geography we have to work out what is best for the whole geography.
Jonathan Benjamin, NCD for urgent care. I think one of the challenges obviously of London is it's a unique city in England, and I wonder how you feel the lessons that might be learned from Vanguard in the North West London region could be translated effectively across England, particularly into more rural areas.
So I think there are lots of urban areas that share some of our problems, but some of the problems are translatable in the sense that where we have problems with congestion, and actually it's a very small geography, but it takes quite a long time to get from one bit to another, there are equivalent problems within rural areas. How do you actually manage the reality of a geography? Do you move the person? Do you move the information? How do you access expertise? I think they're the same set of problems, just with slightly different physical challenges.
Vicky Scott, can you tell me what sorts of efficiencies you're going to drive out through your programme?
So, just Sarah talking about somebody sitting on a hospital ward that doesn't need to be in a hospital bed. If we reduce the amount of time before that person goes home, that person gets a better deal. They get home when they need to get home, and we have used less resource within an acute hospital. That's an efficiency, but it's also a gain for the patient.
Oh, it's Jonathan Richardson. I'm from the North East Network. Thanks for the presentation. Could you expand on what you've done already for patients with mental health problems and what you intend to do as part of the network bid?
Yes, I can expand on that. So we have 2 mental health trusts in North West London, and we've been working very closely, collaboratively, as you would expect through our SRGs and through our networks. Our mental health colleagues have recently produced a very detailed strategic intention which covers both community provision and emergency and care provision. So that out of that has spilled a number of programmes of work which we are in the process of implementing. Sitting alongside that obviously is a huge amount of work from the commissioning point of view, making sure that we've got a lot of the contracting models right to be able to deliver those sorts of services. And I might give you 2 examples. Crisis direct access to care in the community, and the other one is the introduction across all of our hospitals of site liaison services within our A&E departments. I should also add that we have all signed up to the Concordat.
Hello, Kwesi Deborah, Chair of the England Council of the British Geriatric Society. I was very impressed by the fact that you'll be able to get your hospital or your whole unit dealing with one sort of discharge plan, and I just wondered how soon you'd be able to get this to happen, and whether you think there'll be any difficulties in getting your whole group working together to the one plan for discharge.
Quite hard to follow that, isn't it? So it's a huge problem, it's a huge challenge. But of our 8 CCGs and 8 local boroughs, we have already started with 3. So the Community Independent Service is a collaboration between 3 of the local authorities, Hammersmith and Fulham, Kensington and Chelsea and Westminster, and the CCGs, and the community health providers, and the voluntary sector, and patients. And that's a service that's built up gradually over 2 years, and is now, we're unifying all 3. So we nearly have a unified discharge process for those 3 boroughs. And we realise that social workers that go in to do assessments do almost exactly the same assessments as therapists, who will do almost the same assessment as therapists inside the hospital. So we're trying to bring those 3 together, and it is, as a clinician in a hospital, you look at all the medical stuff, and then you look at which borough they live in, and that can pretty much tell you their length of stay. So yes, we're making progress, but you're right, there's a huge challenge on
And I
it.
think an important thing to add is that Imperial, which is our largest trust with the most complex set of relationships, is very highly motivated to sort this out, because they see this as a key way of improving their own productivity and their own patient care.
Could I just add a further comment to that, and maybe add in a comment with regards to the question as to whether we can actually translate this elsewhere? I think that's a very nice example, first of all the right people having the conversation together, so the relationships that we need in order to be able to deliver something complex like that across the system is in play. But the second thing is, it's a nice example of how we can do it in a small area, scale it up within our own area and demonstrate the ability to scale it, and by doing so demonstrating how we might be able to translate it to other parts of the country.
Yes, I'm interested in how you're going to be assessing outcomes. I understand the hypothesis for network bids is that small changes at scale might have a big impact. And you're proposing 15 different streams, as far as I can see, by April 2016. So how do you know which of those may be having a real impact, so that you can tell us which of them is the most important one and others are less important?
So might I just answer that, and I'll answer that in part recognising that I think it was your team that presented that there are a number of KPIs that are required, both from a quality point of view and from a safety point of view. But perhaps our learning to date is both in terms of our ability to have implemented implemented change and to have monitored that carefully and to have understood what it is we were going to change, how we were going to measure it, and then remeasure it again to make sure that we had delivered both safety, quality, and performance. But also we've learnt an awful lot from having to get our performance back up, in that you have to get right down to the granular layer. Every single scheme that you put in place needs to have some sort of logical performance indicator to it that's telling you something about the system and how it relates to other things that it's integrated with. It's a huge challenge, but I think one of the things we want to do as a Vanguard is both learn from others what is out there that we might test and develop our own.
Thank you very much. That's North West London.